Good afternoon, ladies and gentlemen, and welcome to the second edition of a very special webinar series on time to tame typhoid, being organized by Unipath Speciality Laboratory and Vanguard Diagnostics. My name is Veena Kohli, and it's my privilege to introduce Dr. Ravi Gaur to you, who's kindly agreed to moderate this session with distinguished and leading voices from the medical microbiology and molecular domains as panelists. Ladies and gentlemen, Dr. Gaur is the chairman of the Medical Advisory Committee of Unipath Speciality Labs, Ahmedabad, and the founder of DRG Labs. He's a renowned oncopathologist with more than 30 years of rich experience in the fields of pathology, molecular biology, genomics, and immunology. His passion is to channelize the future of diagnostics towards personalized medicine and innovative technologies. So stay tuned as our experts share their insights on the advancements in typhoid detection. Over to you, Dr. Gaur.
Good afternoon, everyone, and good afternoon, Veena ji. It's my pleasure to be here, and thank you for the kind introduction. And I think it is nice to be on a platform where we talk about the new technologies and how the diagnostic is taken care of now in such a rapid pace of the way we are growing in the way, same amount the disease is also growing. So I think, but we are probably now fighting together, and diagnostic has really become a center of everything, whatever matters today. But it's my pleasure to moderate this second webinar of the time to tame the typhoid series. And today's topic, we'll be talking about advancement in typhoid detection. And it's brought to us by thank you for Vanguard and of course my own Unipath Speciality Laboratory. We will be talking today with the leading industry experts, and let's see, I'm finding some solution and giving some solution to our clinical friends, like what is the next step in future life. In the previous webinar, we discussed about the journey of typhoid diagnosis and the current status, how it started from basic, to onwards, of course, to rapid test, Vidal and ELISA, and furthermore. This is basically a three-part series. First one is done. The second one, and third is, of course, going to be 6th of September. But in spite of so much of progress which has happened, the question remains, why we are still not able to find a definite diagnostic test for typhoid diagnosis. There's still we keep doing multiple tests. There are multiple challenges still in our way, and for definite, as we are still in the process of developing a definite diagnostic test for typhoid fever. Some of the things which I probably understood, I think more we understand as we talk to various experts, is could be the pathogen characteristics. The causative agent is Salmonella typhi. It's a bacteria that behave differently from other common pathogens. Its unique characteristic is that it makes it difficult to detect in clinical sample, especially in the low levels of bacteria in the blood, with early infection and intermittent shedding in the peoples. It could be similar symptoms. A lot of other diseases have overlap out here. Typhoid fever, headache, abdominal pain, overlap with infectious diseases makes it difficult actually to differentiate it, to diagnose it at a very, very early stage, purely based on clinical presentation. It definitely needs a diagnostic test. The variant disease cause, actually, it's somewhere, some patients are self-limiting, some kind of absolute complication, and severe and life-threatening. I think that's another issue. Where do you fit in? At what point of time should a diagnostic test? Limitation of the current test. Now, current tests is actually, there are, of course, the gold standards, blood culture we talked about, but there's its own limitation. It takes time to yield results and may require a higher bacterial load for detection sometime. Rapid diagnostics are faster, but may not be as sensitive. Again, we require definitely much better investigation and diagnostic assays to address these. And overlapping endemic diseases, there are various areas where you have the similar things can coexist and leading to misdiagnosis or a delayed diagnosis. Then we have a geographic variation also has been noticed, kind of a thing. And the prevalence of typhoid fever varies across different regions globally. And the genetic makeup of the circulating strains may also differ, impacting the performance of diagnostic tests. Healthcare has always been private in India, especially, and the cost and access is equally important for us. So I think with this, these are some thoughts in mind. I think we have a lot of things to discuss today, and I would like to welcome my esteemed panelists and who are going to be either expert in the subjects. And my, small introduction, we have Dr. Salab Malik. Welcome, Dr. Salab. And it's my pleasure to have you on the panel. Dr. Salab is an alumni of LTM Medical College in Mumbai, and he's a director of microbiology and serology, Dr. Lal Path Lab, with almost over 25 years experience. And he's served in almost very, very good organizations in the past, like Quest Diagnostic, Columbia Asia Hospital, Paras, Primus, Balaji, and much, much more. He is a certified NABL and CAP assessor, and he has multiple research publications. Welcome, Dr. Salab. We're looking forward to hear your views.
Yes, thank you, Dr. Gaur sir, for the kind introduction. Thank you.
Thank you. And we have Dr. Bansi Dhartarai. Welcome, Dr. Bansi. He is Associate Director at Microbiology, Molecular Diagnostic Infection Control, Max Super Specialty Hospital, Saket. And one important role along with that, he plays a co-chairman of Central Infection Control across Max Group of Hospitals. It's one of the largest hospitals probably in the country. He's an MD in microbiology from PGI Chandigarh and has more than 50, I think more than 50 publication. He's also lead assessor to NABL and NABH, and probably a member of various institutions and bodies. And I actually personally have the pleasure to interact with him multiple forums, I think full of knowledge and wisdom. Looking forward, Dr. Bansi, to hear from you as we move forward. Welcome again.
Thank you, sir. Thank you, sir.
Thank you. Now, also with me is Dr. Viral Saha. Dr. Viral is presently working as head of department in microbiology, Unipath Speciality Laboratory at Ahmedabad. He has more than a decade experience in the diagnostic field and having experience of field, especially in TB diagnostic, mycology, serology, bacteriology, infection, of course, whatever today is happening today, and of course with multiple various new technologies even. So, I mean, it's a pleasure to have you here, Dr. Viral. Looking forward to hear from you. And he also has multiple publications in microbiology, reputed journals. I've heard him in a couple of forums. I think this is a panel which is combination of a younger, and of course, I still feel young, and we all are younger in any case in medical field. But I think the very young and the very wisdom-laden seniors, I think probably looking forward for the good discussion. Thank you, Viral, and welcome.
Thank you, sir. Thank you, sir.
With this, I'd like to straight away move to the first question. My first question is for Dr. Salab. Salab, what are the key challenges in diagnosing typhoid fever accurately? And that's the biggest problem I think all diagnostic people feel. I'd like to hear your views, please. Dr. Salab.
So, as we all know, the typhoid is caused by Salmonella typhi and other members, that is paratyphi A, paratyphi B, etc. But there are many factors which are challenging to diagnose this, right from the non-specific symptoms. So it can present as fever, headache, fatigue, or GI symptoms, which are shown by other diseases also. Then the issue of overlapping symptom is also there. Limited clinical distinctiveness. Typhoid can present with a wide range of clinical manifestations, right from mild to severe. Lack of laboratory facilities. Many laboratories are there still in the country which don't have sophisticated blood culture system and the ancillary reagents to identify it, to serotype it, to do the drug sensitivity testing in the fastest possible way. Then, as far as serological tests are concerned, still we don't have a robust antigen test. And the latest in this series, PCR-based test is again limited to the metro laboratories or maybe tier 1 laboratories. Issue of cross-reactivity is very much there in the serological test, which further lessens the sensitivity and specificity of these tests. And in India, whenever the patient presents with fever to any physician, the chances of his taking the antibiotics at the first instincts are very high, and this is also going to influence the results of this investigation. So once you take the antibiotic without putting the sample on test, the yield will definitely be reduced. And then there are co-infections also. So often we have seen dengue presenting with along with the typhoid and all, and other diseases also. So it becomes very challenging to differentiate it. So these are the factors which are quite challenging to diagnose the typhoid fever as of now. So thank you.
Thank you, Dr. Salab. I think I was on mute. My apologies. I think, this is something what we face every day in diagnostic lab, and answering our clinician friend and of course the patient expectation. How do we put that? Because there is a question of, you generally rightly mentioned, cross-reactivity, resources, of course, the blood culture, which is really not, facilities may not be there, right kind of facilities may not be there. And of course, when you talked about, patient coming to us after taking antibiotics, and then I think there's another challenge. There are, I think, various challenges. So I think there's a need here, definitely for something very early diagnosis. And with that, I move to Dr. Bansi. Bansi, I think the question to you is, no, we have it. We just Sharad talked about rapid kind of a thing testing, and the need, of course, is also there. And then the gold standard of the blood culture probably still remains the same. How do rapid blood tests compare to traditional blood culture methods in terms of sensitivity, specificity, and accessibility for diagnostic typhoid fever? That's the all 3 points Dr. Shalab has mentioned. I'd like to hear from you, Bansi, please.
See, rapid diagnostic kit is definitely, it is very easy to perform, and it is very quick. In smaller labs, it can be performed, and it can give you an early diagnosis. Many advantages of rapid diagnostic test is there. And another thing is that if even patient is on antibiotic therapy, then also the rapid antigen can be positive. It can be accessible to most of the smaller set of labs everywhere that can be used. I think this rapid diagnostic test will be really helpful. But see, the blood culture is still gold standard. Why I'm saying the blood cultures, it may takes little time, but you will know what are the sensitivity patterns, and you will know different pathogens like typhi, paratyphi, or other salmonellas, or other bacteria, even non-salmonella species also. But here, even rapid diagnostic kits, I think some have salmonella, mostly have done the salmonella typhi. If you see salmonella typhi and paratyphi, salmonella paratyphi incidence is going up. So we should have a complete test which can detect salmonella typhi and paratyphi A, and the test should be more standardized, like the sensitivity, specificity is not rapid diagnostics is not well established. It maybe varies. Some, I think there are 2 or 3 what I know, typhi dot or Dubex or T-test. I think 3, 4 I know. The sensitivity varies from 70 to 85% or something like. Some are detecting typhi only, some are detecting paratyphi. So we have to have a kit which has a good sensitivity, is a good specificity, and should not be a false positive, like what Dr. Salab told. False positive in case of any viral infection. If you say COVID or H1N1, we have seen many viral infections, respiratory infections, where we have come across antibody typhoid dot positive. So we have to careful in that way. We should have a very low false positive. The antigen methods should be more standardized, but there are many advantages of rapid, and it should be come up, rapid diagnosis should come up, which will be very good. It is very quick, on technician can also perform the test. So these are some of the major advantages, but main is the sensitivity and the specificity, and it covers all the both typhi and paratyphi. These are the 3 important things. And what is the duration? Like we very clear, the blood cultures, Wedal we have a 2nd week, blood culture 1st week. Then we have a 3rd week and 4th week, Basu, like whatever, stool and urine, whatever. So we have a test which can detect at this from the beginning, the day of incubation. It should be defined, more defined, that the antigen test can be from the day 1 of fever or day 3 or day 4 of fever. It should be very clarity on that, on the rapid diagnostic test.
Okay. That's nice. I think we probably are heading towards early diagnosis by using a rapid diagnostic test. But I think it still remains a window of 20%. We are still there is a more specificity, more sensitivity we require. And that's something I think that's the reason I think there's a lot of overlap. Development has happened, diagnostic assays have developed, but I think we still have to address this gap. I think just one question, Consider. I think if you in continuation, this is when should we be doing the day 1 of fever, day 2 of fever, day 3 of fever? Any thought on this, Dr. Bansi?
very clear cut. If you compare on dengue, it is from the dengue day one of fever, dengue NS1 antigen will detect. So typhoid dot it usually pick up in the first week of fever, but now we have to more specific, like which day of fever, like it should be more and clear, and the sensitivity specificity what you told, and the cross false positive what we have seen, especially in the H1N1 and COVID, there are many false positive with typhoid dot. So that has to be ruled out, and multiple antigens should be targeted, not a single antigens like the typhi and paratyphi both. So that is my advice.
I think definitely, probably we will, I think, get back to you on this. I think as we move forward, I think there is some questions also into the chat box, and probably we'll address that. But I think it's important that I think to know, the probably what I understood here is there is a good interaction between the clinician and and the doctor, and especially the history of the patient is very, very important right here. If we have the right information, then we'll be able to give the right kind of assays and the clue to the doctor. Sometimes fever is just about a day's duration, it may not work, and you say typhoid test is negative, it's a false negative. It may not be. I think the communication plays a very, very important role here. And of course, there is always limitations, so we have to talk of the new technologies and that. So when I come back to you, I think when you talk about new technology, I think also I think we have Dr. Viral with me. I like to ask this question to you. No, I think in the era where everything is today, we have everybody talking about molecular, and it's proven its worth actually. So we have, say COVID. Without that, I think India would not have, and the world would not be able to fight this COVID virus. Now, how can the molecular diagnostic techniques like PCR or whole genomic sequencing can they contribute to early detection and monitoring of antibiotic resistance, and firstly monitoring of disease? And then I'm talking about the various the resistant strains, number one. The second question I think I'd like to ask you in continuation, Dr. Viral, because what are the benefits of the typhoid PCR if you want to, and what are its limitations? I'd like to address both questions, Dr. Viral, please.
Yeah, before COVID era, PCR and whole genome sequencing NGS are very rarely used terms, and very few people are aware about the PCR and whole genome sequencing in normal persons in community. But during COVID and after COVID, everyone knows about the PCR genome sequencing, and they also know that the PCR gives the faster results. So in community also, everyone knows that PCR gives faster results, as we have seen in the COVID, that we get the reports in 4 to 6 hours. Same as in typhoid. Before COVID, typhoid PCR are rarely used, but now few companies had started developing kits based on the detection of the typhoid PCR, especially Salmonella typhi and paratyphi A. And what is the reason behind development of these PCR kits for detection of the typhoid? That, as we have seen, that for the detection of the typhoid, mainly blood cultures, Vidal or typhoid dots are used. All these three states have some limitations regarding their sensitivities. Like during the first week of illness, blood culture is the gold standard, and gradually later on at the end of this first week, typhoid dot start giving positive results, and in the second week, Vidal gives positive results. And for the Vidal, we have to do the two consecutive tests at the interval of the few weeks to give a positive typhoid results. So blood culture is the gold standard for the first 7 days of illness. Now the blood culture has also limitations that it has a sensitivity of around 60%. So it may miss around 30 to 40% cases during the first week of illness. Second, if the patient has started antibiotic and later on he gives the blood culture, then also blood culture becomes negative. So that cases may be missed by blood culture. So there is a huge lacuna for the diagnosis of typhoid during the first week of illness. Here comes the role of the PCR and whole genome sequencing, mainly PCR. That PCR if we standardize and develop good PCR techniques which have a high sensitivity, specificity, and targets specific Salmonella typhi, paratyphi, that then we can detect early cases easily, which may be missed by the blood cultures and typhoid. So this is the advantage of this typhoid PCR. Now, what is the other advantages? Like we can do the typhoid PCR from the smaller volume. We do not require large volume like as in blood cultures. Second, we can detect even small quantities of bacteria which may be missed by the blood cultures. So these are the real helpful advantages. Third thing is, if the patient has started antibiotics, then the bacilli will be died. But PCR can give positive results even though the bacteria is died, because it detects the bacterial DNA, whether the bacteria is live or dead. So these are the good advantages of this PCR techniques. Some limitations like PCR, that right now the PCR concept is evolving. There are lack of standardization and validations. We require more sensitive and specificity to perform these PCRs. Now, few companies have started this PCR kits, which have a good sensitivity and specificity. So I can observe, I can see that in next few years or next 2 to 3 years, typhoid PCR will be a game changer for the early diagnosis. Now, the whole genome sequencing. The whole genome sequencing has a role specifically for the strain typing and lineage detection, which is useful for the epidemiological purposes, mainly to control the source reduction, whether the same is strain is same from the different isolates, then we can have a, or if the same is strain is same for the different isolates, then we can have a idea that the source is same, then we can reduce the, or we can control that source, and we can prevent the disease to spread to the other community persons. So whole genome sequencing has a role for the mainly epidemiological purposes right now. And secondly, it can detect the mutations for the specific drugs. So we can have a rough idea that which drug will be not effective in Salmonella by which mutations, and then we can have a target-based therapy based on the whole genome sequencing results. So whole genome sequencing is right now, I think, not used for the early diagnosis, but for the mainly for the epidemiological purposes. So these are the concepts of PCR and whole genome sequencing.
Okay, thank you so much, Dr. Bird. I think what we are really in this era of molecular, I think definitely, I think PCR is what I understood is going to play a very, very important role. And I think sooner or later, I think as and when we have some good kits today, and we have, I think as the era or the way we're progressing faster, I'm sure you'll have a very, very high good quality the kits with us, so that they can detect at very, very low the load, and even probably at a very, very early stage, and all kind of a strain which is like not, and without cross reactivity also. That's something which I think it'll be nice for us and that we're hoping for. And I think one important thing you mentioned about the target therapy, that's something very, very important. I think we'll come back on this because today is the era of antimicrobial resistance. I think this is very, very important. I think we like to ask a couple of questions once after the second round. I think, but it reminds me of a very simple thing when you talk about PCR, because I think we just gone over the PCR COVID phase, almost 2.5 years, 3 years. And at that point of time, I think somebody sent me a few lines, and I think I should recite those lines. This is more of a, it's more relevant today, even for every PCR or typhoid. You say that, as a lab grow with a scientific mind, PCR emerges to conquer the fight. Tiny fragments of DNA's code hold secrets of pathogens that erode. A PCR amplifies a symphony of notes, unveiling invaders on life's very road. Primers and probes, a dance of precision. PCR reveals infections with clear vision. Diagnosing disease, a critical mission. That's what we are all looking for, from viruses to bacterial incision. In the realm of tubes and thermocyclers, heat, PCR's magic makes pathogens retreat. Detecting the culprits, infections still will beat a molecular detective and ultimate feat. I think that's something we all, some kind of magic from the PCR we're looking forward. I think, thank you so much, and we'll come back to you for the next question. I'll just move on to my next question is Dr. Bansidhar. Dr. Bansidhar, I think Viral talked about, the PCRs, and you also talked about rapid testing. And so I think there are challenges, spoke about it. But do you think the PCR and the molecular technologies, we made the first line of test for typhoid diagnosis? Do we have standard case, or at what point of thing? Your view, because you're sitting in the hospital, you see in and out every day complications.
So, sir, before answering that question, so definitely PCR has advantage. It definitely has a higher sensitivity, and PCR. The another important is that even the patient is on antibiotic, you will get positive on PCR. Sensitivity is very high. But the most important thing on PCR, especially I'm talking about salmonella and bacterial PCR. So viral PCR, we know is very well standardized. Bacterial PCR has problem on standardization, especially salmonella. I know is a lack of standardization or validation. That is one of the reasons why it's still not a very good came as a PCR platform for typhoid. And third important, especially for typhoid, is that because we are remaining in the endemicity of typhoid and the immunogenicity what we have, how to interpret this typhoid PCR. So I remember we have initially, I think 4 or 5 years back, we were standardizing the tropical panel fever, especially the typhoid. We could not do the standardization from the directly samples from the blood. So we have standardized after the blood culture came positive, then we do the PCRs. But still, directly from the blood sample, the standardization and is still remain a challenge, especially for typhoid. And what Dr. Viral also, Dr. Saha told is the sequencing things now. Sequencing thing is as coming up, the nanopore sequencing, which is even can detect, there is a very small chips where you can detect all range of pathogens, including salmonella. But PCR, especially bacterial pathogens, especially for salmonella, I'm saying, is because of lack of standardization and validation. So till now, whatever I'm coming to the questions, we cannot take PCR as the first line for typhoid diagnosis. We have to still, our blood culture is a gold standard. PCR definitely help in the early phase, and but we cannot replace blood cultures, which will give us identification. We can have susceptibility and monitor antibiotic therapy, the antibiotics. So at present, I cannot say the PCR will be the remaining of the first choice. Both rapid diagnostic test and PCR are definitely helpful in diagnosis, but at present it cannot be a first line PCR for diagnosis.
Okay, I think that's right, very rightly said, because the blood culture still remains the gold standard, and I think this is definitely going to be there for some time before we actually refine our way, the PCR, and probably it's going to Tame technology is evolving very fast, and I'm very sure the way the things evolved into, if the technology is growing, and if earlier would take a decade for something not going to happening in a year, and I'm sure this is something it evolved. But yes, I think
in fact, sir, if you see the BioFire panel, which is detecting the multiple pathogens and resistance genes, they have developed all upper respiratory panel, lower respiratory panel, GI panel, meningitis, but they have not developed the BCID panel from the blood culture. They could not able to do the BCID panel directly from the blood. It's because of the standardization of the PCR, especially the bacterial PCR is still a challenge.
Yes, I know that. And I was told that they're also working on it. I think that's they've been working for a while, I think. So I'm sure this will be a very, very, good feedback to people who are actually developing PCR technology and who are working standardization technology. I think there's a good feedback for all of us, and I'm sure. But I think there is some role, definitely, maybe not the first line, probably as we move forward. So as probably multiple samples, so maybe from time. Blood is one, maybe stool or urine, or maybe sometime later on, because as the complications grow, because the shedding keeps growing and on and on. The role will come, and role is there, but I think probably as of now, not the first line treatment. That's something what we're talking about.
Right.
That's nice input. I think we all need to take a note, but I think we still the need to develop something which is fast. No, I think Dr. Shalabh, I'll come back to you now, because we heard of rapid diagnostic tests, we heard of the POCD, we talked about the PCRs, we talked about whole genome sequencing, and I'm sure people might be talking about today, the era of AI and analytics, various put together factors. So what do you feel? Have the all the advancement in diagnostic methods will be addressed the challenge of typhoid diagnostic, or still we need to go much beyond? Or Shalabh, please.
Yeah, so right now, as I see, the space looks happy. So for each type of setting, let us talk about the low resource setting or a high resource setting, like reference labs and big labs in the country. So each one has got now different type of testing scenarios available. Now let us look at the blood culture. So we have now automated blood culture to address this. So what my experience is, generally salmonella we are able to retrieve from these bottles within 12 to 24 hours. So moment the blood culture is positive, you can immediately centrifuge it, look at the gram stain, put it under the MALDI-TOF. Now MALDI-TOF can identify in less than 60 seconds. So you have the identification ready. And of course, there is a word of caution that you have to further serotype it to pinpoint whether it is typhi, paratyphi A, etc. Then immediately you can put the sensitivity also on this sediment. So by and large, salmonella workup can be easily done if retrieved within 48 hours with the antibiotic susceptibility. Other is the molecular space. Now, molecular space, we have got a single testing, that is salmonella-based kits also. There are multiplex assays also. BioFire is one, as Dr. Bansi, my friend, just highlighted. But there are other interesting things emerging, like 16S RNA sequencing, which you can do directly from the blood. So you collect the blood in a EDTA-based tube, and you are able to finish the job in 6 hours. So the key is the extraction. The extraction has really revolutionized, where you get the DNA out and look at the various targets. So there are target limited kits also, and there are Sanger sequencing based kits also, which is going to change the game as far as sepsis is concerned, because not only salmonella but other diseases will also be addressed. Then I talk about the your antibody-based rapid test, which will be a boon for low resource settings, especially when we are talking about reaching in our rural healthcare system, where the low scale manpower is available and you have electricity issues and resources issue. So you can easily conduct the blood-based test, which will tell you both about the IgG as well as IgM. Then antigen-based tests are also available. ELISAs are also available. And blood, urine, stool-based tests are also available in this segment. And finally, what I look at it, ever since after the COVID thing has ended, we have got some notification thing happening in our country. Now, all states are very active. IDSP is very active. You can just visit their site. They are asking data from each one of us. I think everybody must have experienced. Some states are talking about hepatitis, some is talking about salmonella. TB is now a legislative bill already. So this gives you a fair idea of what is happening. And the digital space and all these tools immediately tells you which pocket there is an outbreak and what is happening in our country. Besides this, as far as typhoid is concerned, still it is an endemic disease, I will call. Of course, these 4 months, especially from June to September, are the peak months, but then you will keep on seeing this. Now, in the molecular space, what I am further interested to see is the drug resistance also, if we can tell, and if we can differentiate by marrying it with the RNA-based technique, whether the salmonella detected in the given sample is viable or not viable, will settle the score of the false positivity or the latent carrier. And of course, public health interventions are happening, enabling public health authorities to implement targeted vaccination campaigns and other preventive measures. So I think we are now fully loaded, and this molecular thing is going to change how we work as far as salmonella thing is concerned. So thank you. That is all from my side.
Thank you. Great inputs of Shalabh. I think this is something, really, I think you may talk about, especially like, choosing your kit wisely. and process make sure that the cross reactivity, different strains are also probably taken care of, and the extraction, the processes. I think that's something very important part of any molecular test. And I think it stands something similar here. It would be, I think, be careful before you decide what all. You should actually know your geographies well, which strain is working here and there, which is according to you wisely you go for a kit or maybe the selection of kits and technology. I think the cross reactivity is very, very important role to play. But I'm sure, again, I'm sure we all agree that future we are heading towards the molecular. I think we need to be keeping that in our mind as we move forward. I'll come back to one last question after that, Ron, but I think I'd like to mention something about the drug resistance kind of thing. And I think that's a worry which all of us are facing today. And I think as a pathologist, diagnostics, microbiologist, of course, has to be the stewardship leader to be there, talk about it, and make sure that to sensitize our clinical community in fit and various, even patient. So I think, Dr. Bansidhar, I think one question I'd like to ask you is something you also mentioned at the start with various of drug resistance. With the rise of AMR, these advanced diagnostic technologies will help in guiding appropriate treatment for typhoid patients, or it will not, because sometime when we talked about let's do a testing after 5 days or 7 days, by the time patients have already taken all kind of antibiotics. So your views, please, Dr. Bansidhar.
Right. So sir, you ask a very good question. So antimicrobial resistance is the number one problem in our country or even South Asia countries or Asian countries. So here antimicrobial resistance, especially gram negative, is very, very important. And coming to the typhoid, we have seen there is almost 100% resistance to fluoroquinolones. Now there is a pressure on cephalosporins, third generation cephalosporins. So that will be started developing the resistance, and it is the right time where we should have a test where it can detect the antimicrobial resistance faster. And definitely blood culture is very, very important, but here the molecular platform really help in antimicrobial resistance patterns. So a lot of single plex or multiplex PCR has come up. If that is okay, well and good, it will definitely detect the resistance genes. And especially we need some mutation or target genes where we will know the cephalosporins are sensitive or resistance. So there are a lot of different technology. If you say PCR, it is will be helpful. Even also the nano sequencing what is coming up, which will tell you all identification as well as the resistance patterns of the whole genome after doing the whole genome sequencing in the specific nano sequencing. And third, we have other things also, mass spectrometry or biosensor or microfluid. They have different assays coming up, especially the antimicrobial resistance is concerned. And this is the time where we should know as well as the organism and antimicrobial resistance together. Now the different companies are coming up not only PCR with identifications. Now they are all from the beginning. They are targeting both identification as well as the resistance genes. So now the things are changing. Initially, they are targeting only the identifying the bacterial pathogens or the pathogens, fungal pathogens, or maybe. But now they are now beginning itself. They are targeting the antibiotic resistance gene along with the bacterial. So here molecular technique will be really helpful, and because patients already on antibiotic, blood culture may not be positive at all. So here the antibiotic resistance molecular platform will really help.
Yeah, I think very rightly said. I think Wilfred, I'm sure you're sitting in the hospital setting and you must be seeing this in and out every day. And I think the resistance, you already mentioned about cephalosporin under pressure now coming out for the resistance. I think its need is definitely there, and molecular is going to be, I think, looks like a solution or a tool where we can probably, but only thing is it need to be defined, standardized, processed. And I think at what point of time to do it, maybe the cost pressure and everything, I think living with the cost and the, I think, benefits, I think we need to arrive at a protocol here where at what point of time and how we take it forward. I think that's a strong need, and that's the message I think we're getting here. Now, of course, along with that, there is a strong, maybe furthermore, you talked about mass spectrometry, you talked about biosensors. I think these technologies also need to come here. And I think people are working on it, I'm sure. There's a lot of technology development happening today. And I think sooner or later, we are hopeful that we will be able to find something. And because we have to address not the typhoid, the more important is the issue of antimicrobial resistance. That has to be addressed more importantly. Because that, if you really have to, humanity have to survive. I think the way the things are, probably we may be resistant to everything, and then what? Nothing, actually. So I think that's a very important point. I think we just, I think I'll move on to Dr. Shalabh. I think one last question to you. You already mentioned about it, but still, you have a wide spectrum, like across labs and geographies, East, West, North India, and across probably multiple countries nearby also. You have the inputs from all this. You think they consider, have you seen the global variation, probably strains or maybe kind of a presentation or kind of a testing? And if you've seen, how can a diagnostic innovation be tailored out to needs of different regions? Your viewpoint, because you have wide across experience. I'd like to hear from you, Shala.
So we have to look at country as a whole and look at the epidemiological picture, look at the scales of infection, and look at the technology suitability. So what is suitable for low level testing lab compared to a reference lab is totally different. Then you have to see, okay, you are deciding on some, let's say some ABC card test or ABC blood culture machine. You have to see whether it is available in that geography or not. So what are the logistic challenges? What is the training setup? How well they are going to use, and whether whatever strains that are prevalent in that particular locality is giving you results with the established kit or not. So to address that, we have got our validation practices. We do validate the kits before we launch in a particular geography and all. So that settles the score. Then ease of use in low settings where resources are limited, trained manpower is limited. Definitely, we will like to have some easy answers that work well across the specimen type, be it a blood, be it a urine, be it a stool. So it should be able to perform equally well. Then in certain areas where you need to act fast, otherwise what is happening in India, especially in rural and tier 3 settings, a lot of empirical work goes on. So there is a tendency to give you a mixture of one anti-malarial or maybe anti-typhoid drugs, etc. So something on the spot, that is a rapid test. If we can do and tell immediately, look, typhoid exposure is there, so you can fine tune your treatment. And of course, cost effectiveness has to be taken into account, especially in countries like ours, where it is out of pocket expenditure. So still our country is not covered by the medical insurances, etc. So that is why this high-end test, high-end sequencing-based test, or be it a blood culture, etc., they have got limitation. So these, fortunately, this card test or Vidal test, they follow in that genre where affordability can be considered. Then community engagement is also important. Involve the local communities and healthcare providers for the development and implementation of diagnostic solution. So still, as a country, we are lacking a established algorithm. Look, if you are suspecting a typhoid fever, so these are the ABC steps you need to follow. And not only follow, but then there is no monitoring committee on this. But good thing is now on the antibiotic front, we have a WHO-NET program. People are entering their data of antibiotic into it, and anybody can view it, what is happening for which organism, what is the susceptibility and resistant pattern going on. Similarly, ICMR has also come out with a booklet which gives you the hint. Look, quinolones are not that good as far as typhoid is concerned. Other drugs have to be taken into account, and surprisingly, the chloramphenicol, which we have seen in our childhood as the first line drug, which was abundant, is showing now 100% susceptibility. So this again emphasizes the concept of drug holidaying, etc. And training and education will be fundamental. So whatever technology you use, you have to educate the people rightly. You have to provide them right SOPs, right QC framework, And there has to be robust EQUAS and third-party monitoring system, which unfortunately is what I will say fill in the blanks in our country. So thank you. This is all I have to say. Thank you.
Very rightly said, quality matters. In any case, in anything, I always believe this, for every sample is a life. That's what a tagline goes. I think everything quality, quality. Let's not compromise in quality. And that's a message has to go down the line to everybody for that matter. And I think even for our customers, the patients or doctors, they should also probably insist on the quality. I think the drive has to be both ways, providers and of course the users. I think the one thing you mentioned about AMR, I think I was part of some event here. Maybe really presenting some data because a lot of awareness is happening, especially in hospital and the providers, healthcare. But I think 50% of the people in India, they go over the counter to the pharmacy and take the antibiotics. I think this is where I think we need to work on because that's something causing the maximum, probably the cases of AMR, maybe, and that's spreading. I think the awareness, what you mentioned, is very, very important at that level. So how to talk about, let's talk to at that level, and that probably help us out future. I think, there is nice, one, I think, question, I think, like the audience before I move on to viral. What is the most common AMR resistance reported in Salmonella typhi in Indian population? Anybody, you or Bansi, or anybody can answer. They were asking.
My opinion, it is quinolones, ciprofloxacins, are the bad boys as far as typhoid is concerned. And other drugs are not that bad. Ceftriaxone, okay, drugs are resistance is emerging, but still I think it is below 4 or 5%. So quinolone will not work. That I am seeing in majority of the cases it is resistant. So Dr. Bansi, you can add further.
Dr. Bansi, you can also maybe add what is the percentage of AMR positive, because in the hospital I'm sure you must be getting some kind of workup on it. Dr. Bansi, please. Yeah.
Yes, sir. Sir, like Dr. Sarlab said, fluoroquinolone resistance, if you can see, it is around more than 90% or 95%. The ampicillin resistance, it can be vary from 30 to even goes to 60, 70%. Co-triamycin resistance is a little less. But nowadays, cephalosporin resistance has just come up, not much than, I think, 2 or 3% cases. But if you say commonest is the fluoroquinolone resistance. That is even if you see around 90-95%, because it's already, although it will become susceptible, but it will be not effective in most of the type of cases.
Viral, anything you have to add here?
So
in fact, there's a question for you, I think is already there. This is in addition to what is detection of typhoid, what is the best sample, especially if you get the whole blood, plasma, Buffy code, urine, stool, whatever the best sample you feel, you can address that.
Sir?
Dr. Viral, please, yeah. Or any Dr. Bansi, anybody for that.
Yeah. So definitely, what is the blood culture? Definitely, blood will be the most important samples. The whole blood culture, and what is the query for detection type? What is the base samples? Whole blood, all cells, RBC and WBC. Plasma. So basically, sir, another point I want to highlight here. See, there is in CBC. So I have done a study where we have an index, that is mean monocyte volume index and mean monocyte volume index, and what is the SD standard SD of monocyte index. So in that, I think the 5-part the 5-part hematology analyzer, it will give some the index values. Basically, monocyte and total TLC index. In that, we have a paper. I just forgot to add. In that, if index value, monocyte index value is more than 85%, there is a high suspicion that the patient is having typhoid. So that that is published in the Indian Journal of Physician or something. One of the DNB students were doing. So that is another part which has not come onto the public domain, but you can find some papers where is monocyting index, mean monocyting index. That is another important.
Bone marrow is one of the good sample because it has a highest load for detection of the Salmonella typhi or to isolate the Salmonella typhi from the bone marrow. But practically, it is not possible to collect bone marrow in every patient. So blood sample is the one of the good sample to collect.
One more thing I will like to add over here. See, first week of fever, blood is the best sample. And then urine will come, and then lastly stool.
Long
Okay.
time you is too likely.
Yeah, so that order you have to remember. And as far as bone marrow is concerned, especially when the entire treatment has been spoiled, and you are dealing with something called pyrexia of unknown origin. So that is the time one has to hit the bone marrow and get it cultured or get it any other investigation done. So I will advise that order. Okay.
I think we've addressed a couple of questions. I think I'll come back to Viral. I think one of the questions is important. Now we've talked about every technology, advancements happening, challenges. So what is the main factor which is which can influence the adoption and implementation of the advanced technology? Why it is like there is a technology existing, there are advancements happening, but still I've seen first line is straight away right Vidal. Don't even talk about typhoid or maybe talk about what blood culture. This straight away. What are the main factors which are influence adopting and implementation? Because this also like to address one question here in the box, which is like we say the blood culture need moderate to high numbers of bacteria to culture. However, the drug administration before seeking advice from clinical practitioners may also have challenge for culture positivity. Because people already taken an antibiotic. What should be a strategy applied in this case to diagnose typhi and paratyphi, keeping in mind that it is a limitation and the rapid test is all sensitivity and specificity. Vidal may not have sufficient antibody level against H1 antigen. So I think what are the main factors influencing, because there is a need, but why it is not been there? So you might like to address that, Viral, please.
Sir, so main factors which influence is like the clinical picture of Salmonella. It looks like so many other infectious diseases. So sometimes Salmonella remains undiagnosed for the first few days. And every test which is used to diagnose Salmonella, like Vidal, typhoid, blood culture, have some limitations. Like Vidal have a sensitivity of around 70 to 75%, and specificity somewhat lower because it has chances of false positive results. Typhoid has a sensitivity of around 80 to 85%, and blood culture has a sensitivity of around 80%. So there is no any
let me just interfere. There's a question in the box, and immediately we address it right when you're talking about. Blood culture takes a lot of time and requires a well-equipped lab, which is the next best test for early detection of typhoid. But you already, in any case, you're talking about sensitivity. You can address that also.
So there is no right now that gold standard and confirmatory test. Although blood culture is the gold standard, but there are some limitations of the blood cultures that it doesn't pick up the Salmonella early in the early phase of the early few days. So now the PCR role is here, that PCR and targeted PCRs for Salmonella typhi and Salmonella paratyphi that can detect the Salmonella for the first 3 to 5 days when the bacterial load in the blood is somewhat lower and blood culture didn't pick up that bacterial load. And if we standardize the PCR for that lower bacterial load, which can detect easily the typhi and paratyphi, then that will be the game changer in future. So these are the main factors that lack of good sensitivity, specificity in Salmonella detections is the main influencing factor for the adoption of the newer technologies.
I think, yes, there is again the very important factor because blood culture still remains the gold standard, but there is definitely for early maybe clinically highly suspecting typhoid, maybe PCR can play a role because third, fourth day, or maybe I think we have a rapid test like typhoid, maybe a 48 hours something. Those could be, but I think there is no definite algorithm today. But I think we have to go by probably the symptoms and clinical findings what the clinicians feel. But I think everything has a role here. And I'm sure molecular would play a very, very important role as we move forward. I think all of us agree on that front. That is something which is, brings to almost all the questions. But I think, I don't know, because if anybody is there who can answer one question, because this is more of a clinician, but I'm sure all of you are interacting every day. Is the treatment algorithm same for or different for typhi versus paratyphi? Anybody, or Shala or Bansi or will anybody like to take this question?
Yes, sir. Clinical symptoms varies between salmonella typhi or paratyphi. Like even I think constipation is more common in paratyphi, and loose motions is more common in typhi. The typical type of fever. There are many factors are there where you can judge little bit whether it is salmonella typhi or paratyphi. One or the is constipation and diarrhea. I know.
Second is paratyphoid fever have a somewhat lower and milder symptoms than Salmonella typhi in general.
Right. And respond to therapy also paratyphy, I think it takes little bit longer time. Fever also it takes little bit longer time in paratyphy. So these are few parameters we have not studied. But one thing, sir, I was talking you because you know much on there is a one vicious parameter. You know, in hematology 5, we have published in Journal of Laboratory Physician, I think 2018, inside universe. So there is a we have given a cutoff. If a more than 185 mean monocytic volume and there is a sensitivity of 85%, there is a patient will be of a salmonella species, because that is a study research we have done. My DNB students have done. So it has not come up to most of the clinicians, but if you study, they can go to the Journal of Laboratory Physician, which I have published, especially for salmonella.
Even one finding of eosinopenia, if you look at all these typhoid cases, you will see 0 value in eosinophils, especially all typhoid positive blood cultures. There are publications also regarding this about the eosinopenia, absolute 0. So that is also there. And finally, I will say the wish list is not only by molecular test, you tell it fast, but you also comment about the drug resistance. And last in the wish list will be you differentiate whether the bacteria you detected in the sample is a viable or a non-viable. So, which is a reality, which is not far from this point of time, and that will totally change. And as we are approaching towards the precision-driven medicine, so this empirical way of writing the treatment will also change. Our behavior will change. And as you know already, ID physicians are also there in our country. Compared to US, we are still very less. In US, it is more than 10,000 ID physicians are there. So all these things will drive us towards precision-driven medicine, and this is the space where molecular will take an edge.
Yeah, I think very rightly said, because this is an era of precision medicine or personalized medicine for companion diagnosis, target therapy. And I think the togetherness, probably the integration is very, very important. On one side, advancement in diagnostics. On the side, it is the development happening, the R&D is happening academically. And of course, the labs who are actually taken in and out in hospitals to seeing the patient. I think the integration is going to be the solution for a while to start before we arrive at some common conclusion. I think with this, we have almost come to an end to our discussion. Anybody want to have our last 1 minute, anything to talk about, or I think we move on to the end of the session. Anybody, Dr. Viral, Salab, or Balsida, anybody want to add something here?
No, sir, I think most of the things we have already discussed, and you already saw the newer technology will come. Need more standardization of the newer technology, especially maybe in the rapid antigen or molecular. But they will really help and go further, because blood culture it is from the beginning. So many years we are doing, but this is the newer technology which will go, and at least what we are lacking, especially the sensitivity percent of blood culture, which is most of the patients come refer to our hospitals. The initial phase they start antibiotics. So there is a problem whether we got blood culture positive. So this will be really help.
I think, yeah, Viral, please.
Yes, sir. So my opinion is that the PCR and whole genome sequencing now will evolve in few years. for the detection of typhoid. But the blood culture, typhoid and Vidal have also its special place for the diagnosis of typhoid. So all together tests will detect the typhoid cases which are missed by routine individual single test. So all tests have an importance, and we do not have to rely only on the PCRs in future. That's the message.
Yeah, I think right. I think we have, what Shalabh mentioned, one important point, the finding of CBC. And I still remember the first session. I think we have a very esteemed microbiologist talking about like CBC is very, very important role. If you look into the CBC, probably we had, I think, if I remember, Kanpatha Roy, who was another leading microbiologist and virologist. He mentioned about this, I think one of the first easiest tests could be CBC, and that can actually give an indication into what exactly the typhoid is. I think with this, I think thank you so much. And there are a lot of things that are happening, and I'm pretty sure all of us are looking forward for a technology. We are excited about it. But yes, we have to, as we handle with the blood and the human patient, we have to be cautious. But there is a strong need of a molecular testing, there's a need of a new technology, standardization to avoid the cross-reactivity. And with this, I think I'd like to, before I finish, I'd like to say a few lines. Development of rapid diagnostics that can detect specific antigen antibodies related to Salmonella typhi bacteria responsible for fever have made diagnosis quicker, definitely, more accessible than the traditional culture-based methods. Additionally, advancements in molecular techniques like PCR has improved the sensitivity and specificity of diagnosing typhoid fever by detecting the genetic material of the bacteria. And that's probably, we are talking about, POCT, PCR, multiplex testing, whole genome sequencing. Maybe in a public health domain, we talk about AI and data analytics and coming out some kind of diagnosis out. Addressing these challenges requires a continued research and development of innovative diagnostic technology, and its intense collaboration, integration with the researchers, the manufacturers, maybe the diagnostic guys and clinicians, and every patient together. It's important to note that medical research and technology continue to progress, and there are newer advancements happening at rapid pace. Again, I think Shalabh also mentioned about we need to aware what's happening at a very, very fast pace, because we may develop something today, and by the time you start implementing it 6 months, a day later, technology has already changed. Keep pace with technology. Now, in this era of innovation and development of new tests, we need to continue our journey of revealing the truth of disease, giving life a fighting chance. With technologies at forefront, it's time to embrace new and newer diagnostic tests, harmonizing hope and health with every result. I'm sure from molecules to markers, new tests will pave the way with more precise and accurate diagnosis. I'm also very sure in the art of healing, new diagnostic age will take over the stage and rewrite health's next page. And as ever, amidst uncertainties, new diagnostics will stand tall with the celebration of clarity, insight guiding us through it all. With that, thank you so much, all the panelists, Dr. Shalabh, Dr. Viral, and Dr. Bansidhar. This was nice of you to be sparing your time. I'd like to again thank Veena Kohli, who's Vanguard and who's been supported this kind of the education program, making it aware there's something new we have to be working on, and new technologies are there, and we should start adopting them in our practice. But yes, with cautious, and we move forward. With that, thank you everyone again, and back to Inaji, please.
Thank you, sir.
Thank you. Thank you
so much, Dr. Gaur, for concluding this very engaging webinar in such a poetic manner, like you always do in your own signature style. And thank you very much, Dr. Shah, Dr. Bansidhar, Dr. Malik, for giving us a comprehensive overview about the advantages and disadvantages of the existing tests for the detection of typhoid and possibilities of introducing more advanced tests in the future. And a special thanks to Dr. Bansidhar and Dr. Malik again for giving us the insight of a possible correlation between the monocyte and eosinophil levels with the presence of Salmonella typhi in a blood sample. And of course, we must thank our attendees who tuned in today. And I thank you all very much once again. Thank you very much, Dr. Gaur, for moderating this so brilliantly. Thank you very much, and have a good evening, everyone.
Thank you so much, everyone. Bye-bye.